Good morning, everyone, and welcome to our Tyro multidisciplinary seminar. I hope everybody, at least who is in the U.S., who is joining us, had a wonderful Thanksgiving. We're back after a one-week hiatus, and really have a terrific panel this morning with an outstanding and I think an extremely valuable piece of work that was done in Europe, and we're going to bring that to you this morning by Dr. Dana Hartl. Dr. Mark Zafereo will be discussing this paper, and we're going to sort of mix this up a little bit insofar as Dr. Zafereo is going to provide a little bit of commentary and open up discussion as Dr. Hartl is presenting. And so, as always, we ask all of our participants to send in their questions. I will do my best to get to those questions during the course of the hour here. So, as I'm sure many of you who have logged in the past know Dr. Hartl as a head and neck surgeon and chief of the thyroid surgery unit at Gustave Roussy Cancer Institute in Paris. In addition to her expertise in thyroid surgery, she also is a head and neck cancer surgeon and also manages problems related to the field of laryngology. Her particular expertise in thyroid include locally invasive and recurrent thyroid cancer. And as is germane to the particular topic this morning, she is principal investigator on a prospective clinical trial evaluating the role of prophylactic neck dissection. Our discussant this morning is Dr. Mark Zafereo, who is a professor of head and neck surgery at MD Anderson Cancer Center. He is both the section chief of head and neck endocrine surgery as well as the associate medical director of the Head and Neck Center. He serves on the boards of the American Academy of Otolaryngology and Neck Surgery and the International Thyroid Oncology Group. He has and continues to play a leadership role in national clinical trials investigating the role of neoadjuvant therapy followed by surgery for both anaplastic and medullary thyroid cancers. And so I think what we will do is go ahead and delve in here. If we could just bring up Dr. Hartl's slides.
Oh, well, I just want to thank Mark for that really wonderful introduction. Thank you. I'm very honored, and it's a pleasure to be able to present our work. And it's just even more pleasure to be able to do this with my friend and colleague, Mark Zafereo. So we're going to talk about a publication that came out this past year about in the European Journal of Surgical Oncology, looking at prophylactic unilateral central neck dissection as a means of staging clinically low-risk papillary thyroid carcinoma. I do have a disclosure. I'm a consultant for Medtronic. And so why is there's this dilemma about prophylactic neck dissection? And it gets to be almost an emotional debate sometimes. Well, the problem is that ultrasound has limited sensitivity in the central compartment, and there are a lot of micrometastases that are missed. And so the sensitivity ranges in these different studies. With the thyroid in place, we are going to miss some of these micrometastases. And when we do a central neck dissection, a prophylactic central neck dissection in clinically ultrasound neck negative patients, we are going to find, even for microcarcinoma, a certain number of micrometastases. And the rate of micrometastases increases as the tumor size increases, as you can see from one of our older publications. So we know they're there. We know those micrometastases are there. But even if you don't remove them, patients are going to do very, very well. And you can see from this slide, I really like this slide from Jan Hay and this wonderful study over many, many years, just showing that even if we don't remove these nodes, I know they're there, the patients will do fine. So that's kind of a strange thing in oncology, to know that cancer is there and not do anything about it. So that's the first dilemma. And so what do the guidelines say about that, though? Patients are going to do well. And so the guidelines say that they suggest that prophylactic central neck dissection may be useful, should be considered in patients who have advanced tumors, as we showed with more likelihood of having a lot of more metastatic disease, or with clinical nodes in the lateral neck. That's a whole nother subject. But then they go on to say if the information would be used to plan further steps in therapy. And that was the question that we addressed in this study, was how what kind of information can we get from a unilateral prophylactic central neck dissection for these low-risk patients? And further therapy, meaning radioactive iodine. So if you do lobectomy, and in what cases are you going to be wanting to give radioactive iodine? Which patients are going to be upstaged with the neck dissection, which is recommended for patients who are N1A, generally recommended. And then again, there's maybe insufficient data for these tiny micrometastases, but we are still going to be saying, well, these are intermediate risk patients, so maybe we are going to be wanting to do completion thyroidectomy and radioactive iodine on them. So this is the information that we're looking for to plan steps in further therapy, as the guidelines say. And it is sort of, well, I don't know how to say it. It's sort of contradictory to say, okay, we're not going to do central neck dissection, but then we should or we shouldn't. But it is interesting kind of to know what's going on in the neck, because we are going to stage all these patients according to what's going on in their necks. And again, intermediate risk patients are probably going to, well, we're going to want to discuss radioactive iodine on that. So what kind of brought us to do this study was that it's the big fashion in France. La mode is fashion in France. I don't know if people are doing it where you are, but it's to do lobectomy and a unilateral prophylactic central neck dissection as a staging procedure. Maybe also not to have to go back in. That's an old kind of a discussion about among surgeons. But then even for some of my colleagues who are doing this, they're doing diagnostic surgery and doing the neck dissection with diagnostic surgery. So the fashion has gone a little bit wacky in some respects. So the question was, how often does this practice of unilateral prophylactic neck dissection actually change further therapy in these patients? That is, in what cases do our clinically low-risk patients actually become intermediate or high risk from the information that we got from this neck dissection? So we did a retrospective study. We looked at only intrathyroidal unifocal T1B, T2 clinically and ultrasound N0 patients. All of these patients, as I said, you got to keep this in mind when we see the survival curves and recurrence rates. They all had total thyroidectomy and bilateral prophylactic central neck dissection, which is what we used to do. And again, this is like some of this is older data, so that'll be part of the discussion as well. Keep that in mind. We only used adult patient files, papillary and variants, 11 to 40 millimeters. We looked only at unifocal unilateral cancer. We didn't, anything was bifocal, anything was isthmus. We eliminated that. So this is just really only unilateral, and no suspicion of extrathyroid extension on the ultrasound. We also eliminated some of these more aggressive subtypes just to try to get something a little bit homogeneous. We did have patient files with missing data that were eliminated as well, of course. So what we looked at was, first of all, the pathology report. We did not redo the pathology on these patients. We just looked at their pathology report and looked at in which cases, how many cases, the primary tumor had intermediate risk features. So aggressive subtype, extrathyroidal extension, vascular invasion or BRAF mutation. These are all from the American Thyroid Association guidelines. And then in which cases did we see high risk features in the primary tumor. Then we looked at the ipsilateral prophylactic neck dissection specimen on the pathology report, and looked to see in which cases they also had intermediate risk features, more than 5 metastatic nodes, or a lesion more than 2 millimeters. We're talking about the metastasis in the node and not the size of the metastatic node itself, but the size of the metastatic focus in the node. And then how many patients had high risk features. So the main objective, as I said earlier, is the rate of upstaging from low, clinically low, to intermediate or high risk, based only on the information from that central neck dissection. Beforehand, and then looked at the contralateral lobe and the contralateral prophylactic neck dissection because we had that information, and then response to therapy at last follow-up. So we found 303 patients, classic 80% female, 45 years old. Again, 80% of the cohort was treated before 2016, which is why we do have so much of that neck dissection. The median tumor size was 17 millimeters. There were some microcarcinomas. They were 11 millimeters or 12 preoperatively, and they shrink down when you get them into the pathology report. And a little over 2/3 of these patients were T1B, and about a third were T2. So on pathology, 37% of the patients did have metastatic nodes in the central neck. And when we looked at the primary tumor intermediate risk features, 23% had extrathyroidal extension. Aggressive histology, only in 6.6% of the patients. We did have missing data on vascular invasion because these were earlier pathology reports. We do report it systematically now, of course, but it was present in the 181 cases where it was noted. It was present in 30% of the cases. Nowadays, we do also our pathologists try to tangle out whether it's venous or lymphatic invasion, which may also be interesting, but we didn't have that at all in our study. And BRAF, of course, again, because it's an older study, we only had 13 patients tested for BRAF. But what I thought was a little bit interesting was in these 5 patients, BRAF was not an independent factor for upstaging in these patients to intermediate risk. They all had other factors, and none of the tumors had a high risk feature. So then when we look at the lymph nodes that were removed in the central neck, medium and 5 nodes. In the patients that had metastatic nodes, they had a median of 2 nodes and the medium size of 2 millimeters. So we're talking about tiny metastases. And so patients who met the criteria for upstaging to intermediate risk, about 6% had more than 5 nodes. 14% had nodes that were bigger than 2 millimeters, and then some of them had both of these features. So this is a little schematic that kind of summarizes what we did. We looked at, and the results, we looked at the lobe. And so in a little over a third of the patients, the primary tumor itself upstaged these patients to intermediate risk. And so we would think about, discuss completion thyroidectomy and radioactive iodine for these patients. And then a little less than 2/3 of them were still low risk on the primary tumor. And when we added the prophylactic neck dissection, only 13% of these patients, or 8.6% of the whole group, were further upstaged to intermediate risk. So it really only changed the game in 8.6% of our cohort. This is what I just said, 8.6% of the group were upstaged based on their prophylactic neck dissection. And if you look at the patients who were already intermediate risk based on their primary tumor, they also had some intermediate risk features in their nodes, but not that much either. It was about the same in both groups, actually. If you look at our complications, this is after, like I said, total thyroidectomy and bilateral prophylactic neck dissection. And these are, low or intermediate risk patients. We did have 1.3% hypoparathyroidism, which may be underestimated because, as we all know in retrospective studies, that complications, we don't always have all the data on those. But this is basically what you can find in other previously published reports from other groups. There was a case of bilateral local fold paralysis, and this was some of the older cases where neuromonitoring, for example, wasn't used systematically. We did not find any clinical factors that could predict upstaging with the lymph nodes, age, sex, and preoperative tumor size were not factors. If we looked at the contralateral neck, an additional 6 patients had a few more lymph nodes and were upstaged a little bit more, so that really didn't match. It was very, very small amount. And if we looked at the contralateral lobe, there was no change in risk groups. Just to get the end of the story in all these patients, 80% of them had radioactive iodine, again, because it's an older series. And there were, if we looked at patients who were upstaged based on their primary tumor versus patients who were upstaged based on the lymph nodes, there wasn't a difference in doses, but patients who were in the intermediate risk group, whether it was primary tumor or lymph node intermediate risk, they did have a few more doses of radioactive iodine, and this was actually statistically significant. And on mean follow-up, you can see here we do have a very high rate of excellent response, as we know in these low or low to intermediate risk groups. One patient did actually surprisingly die of disease 10 years after being treated. He showed up with distant metastases that were anaplastic thyroid cancer. So you get some of these, we can never say never in medicine, but this is really a group that's going to have an excellent results. Yep. And if we look at event-free survival, we had a median follow-up of 7 years. And the 15-year event-free survival, these curves actually split up significantly between the low risk and the tumor intermediate risk patients. And these lymph node intermediate risk patients, this green curve here seems sort of to be in between, but there was no difference between the low risk group and the lymph node group if we take them individually, or the lymph node group and the tumor group. So one of the drawbacks to this study is that it was, like I said, retrospective and some of the older data. And as you can see, nowadays, I think ultrasound has gotten much more sensitive to diagnosing. This is like a tiny lymph node that's 5 millimeters, and we've got some microcalcifications in here. This type of tumor might have been actually included in some of our earlier patient files. So our data may actually overestimate the rate of occult metastases nowadays that we have these much better ultrasound machines, and also the expertise. I think maybe at the time as well, I mean, we did a lot of our own ultrasound, but I think more and more today, we all understand the importance of an expertise in ultrasound in thyroid cancer. Yep. And I think I'm going to go on a limb here, and I think these are some of the issues that Mark is going to talk about. But so, and there's lots of question marks that I think these are questions that we really need to ask ourselves and investigate. So, is upstaging in 8.6% of this cohort, or 13% of the low risk tumors, really clinically significant? I would go out on a limb like this scroll and say that maybe we're overtreating. If we're doing this, we're overtreating 85 to 90% of these patients by doing this neck dissection. So, is this something that we should promote to get more information on intermediate risk patients or not? I don't know. Would there be an impact on oncological outcomes? Does it impact the oncological outcomes if we if we do this in these groups of patients? Is it in the patient population? Is it really going to make a big difference in terms of our survival? As you saw the curves, probably not. Another argument that I hear is, oh, it's just a lobectomy and a unilateral neck dissection, so that's okay if we remove a parathyroid or two. And yeah, of course, unless you want to go back in and you're going to have to do the completion on these patients, or even if we just follow them up and they have, other parathyroid issues on the other side, does it may impact, I think doing more surgery than what's really necessary, we have to really be careful because we really don't know what's going to happen to these individual patients later. Anyway, so not a big deal removing a parathyroid. I have a hard time saying that's not a big deal. And then one of the real questions that I think we're all wondering about is which patients truly benefit from radioactive iodine. And that's really the question. So which patients really need completion thyroidectomy and radioactive iodine? So what we base that decision on nowadays are clinical features and pathological features, of which we have our lymph node data. But I'm going to get on my little space shuttle here and go off to the future and venture to say that I hope, at least I think, that in the future we will be basing indications for radioactive iodine more on molecular features and biological features rather than on clinical and pathological features as we do today. And there's, of course, the BRAF-RAS dichotomies is probably most definitely oversimplifying things, and the big picture is much more complex, of course. But I think as we're getting more and more data, the picture is becoming clearer and clearer, and that we'll be maybe basing completion thyroidectomy, radioactive iodine on molecular features, and maybe even upfront molecular features, even before going into surgery for some of these patients. And I'd like to say, even if some of these patients are going to be radioactive iodine avid, we're going to have to be looking also at the pathological features that predict a radioactive iodine responsiveness, because tumor can show uptake, but the radioactive iodine also can have no biological effect. So I think that's sort of the dream world for me would be to have some sort of a molecular test up front to say, okay, this is a patient that's going to, need radioactive iodine, or going to do better if we give them radioactive iodine up front instead of having to try to tangle out these pathological features. So to conclude, and I guess I maybe talked too fast, but we'll have time to discuss. Again, I'm putting up this little schematic. About over a third of patients are going to be intermediate risk on their primary tumor, or were already in our case. And adding this lymph node information only upgrades patients in 8.6% of the whole group. And so I think this really has to be taken into mind when we're doing this. And keeping in mind also that we really, when we look at the survival curves and we look at how well these patients do, we really have to be very careful to do no harm first and foremost. So I want to thank you for your attention, and thank you again for the invitation and the honor to present our work. And I'll let Mark Zafereo raise his hand.
Great. Wow, that was such a great presentation, very provocative and educational from Dr. Hartl. Really enjoyed that. In summary, over 300 patients treated retrospectively, or sort of reviewed retrospectively over about a 15-year period, 80% of whom were female, and these were T1 and T2 papillary thyroid cancers who underwent total thyroidectomy and bilateral central compartment dissection. About 8% of them were shown retrospectively to have been upstaged based on the prophylactic central neck dissection from a low risk, mostly to the intermediate risk category, or to a few of them to a high risk category. I think I look forward to a very robust discussion. I have a number of questions and comments. I think, Dr. Hartl, your group has been a leader in sort of thyroid cancer clinical trials and sort of setting the tone for guidelines for a long time, not only for surgery for thyroid cancer, but also for adjuvant treatment. And so I think in the big, I wanted to have a little bit of conversation about sort of the big picture and sort of where we're heading as a field, and put that in the context of this study. One of the things that I think is very interesting is the continued sort of push for de-escalation. We have the push for active surveillance, and that's been led by sort of the Asian group, the Japanese and Koreans. I saw we have Dr. Iwo Sujitani on the call today, and also the Memorial Sloan Kettering group. I saw we have Dr. Shaha. So on the one hand, there's this increasing push for de-escalation, even active surveillance now pushing the envelope for that beyond just 1 centimeter tumors. Now we're looking at 1.5 centimeter tumors, even to the T1, T2. So there's that aspect. There's also the de-escalation that we're seeing in terms of radioactive iodine. I think back in 2010, 2011, we started to see several New England Journal of Medicine articles published on sort of this idea of de-escalating radioactive iodine, and that was that was led, at least some of those studies were led by your group, Dr. Hartl. And so this idea of de-escalating radioactive iodine as well. And so, and you mentioned, the other thing you mentioned is molecular status. So particularly BRAF status. So we've come to sort of understand that BRAF mutated tumors are not as sensitive to radioactive iodine. And so sometimes our endocrinologists at our institution, if the BRAF status is known, will sort of use that as one of the criteria that are used to determine whether or not a patient may get radioactive iodine. If a patient being BRAF mutated, they may not receive radioactive iodine because they're not thought to be as sensitive to radioactive iodine. So, and I think the other point I wanted to make to bring up for discussion is we're essentially talking about a fairly low risk group here. So we would expect these patients to have, as you mentioned in your talk, very good long-term survival, 98, 99% long-term survival related to their disease. 80% of these are women. A lot of these are kind of young and middle-aged women. So we would expect them to do very well. So what we may be talking about in terms of doing the central compartment dissection or not may be more of a recurrence issue than a survival issue. And so that's another thing that we may want to discuss. But so we'll kind of go through these things, and I wanted to sort of provide this brief overview, and then I have some specific questions. So my first question for Dr. Hartl, one of the things where we've been moving toward at our institution, and you sort of alluded to this very well in your sort of the French fashion slide that you showed, where sort of the trend toward a unilateral surgery. That's been a trend also in the United States, where for a lot of patients with papillary thyroid cancers less than 4 centimeters, we've been moving toward a unilateral surgery, lobectomy. And usually with that unilateral surgery, my personal practice is I will send a couple of lymph nodes for frozen section. If those lymph nodes have metastasis, then I will go ahead and complete the central compartment dissection on that side. So it's essentially a unilateral surgery is what we're talking about here. And it's very rare that we would take a patient back for completion, even if we would have a patient who may have 5 metastatic lymph nodes, which would put them into the intermediate category. I think the bar is a lot higher to take a patient back for completion thyroidectomy and radioactive iodine than it would be to just have done that surgery up front. So that has been our primary strategy, is sort of a unilateral surgery for those patients, basing the central compartment dissection often on frozen section. One of the advantages to that is you actually had outstanding results for a total thyroidectomy bilateral central compartment dissection cohort, very low rates of temporary and permanent hypoparathyroidism. But if you just do a unilateral surgery, your rates of permanent and temporary hypoparathyroidism are essentially zero. Certainly you do have to preserve the parathyroid glands and give attention to that. And then your risk to the nerve is also fairly low. The most of the time, the highest risk to the nerve, at least what I would argue is when you're actually taking out the thyroid itself, really that nerve right at the ligament of Berry, kind of where you're, and oftentimes it's like a stretch or, a stretch injury where you have that temporary neuropraxia and it's often that nerve really gets sort of stretched there at the ligament of Berry, and those typically recover with time. But I've found that the risk when you're doing the actual paratracheal work itself, the risk to that nerve is very, very low. I don't think that adds a lot of risk to the nerve. I think that, again, the primary risk is when you're actually taking out the thyroid itself. So I wanted to get your opinion, and maybe we can also bring in a couple of our members from our audience. I would love to hear what Dr. Shaha has to say afterwards, as well as Dr. Sujatani. But first, what do you think about this unilateral strategy? Unilateral, and is this something that you think will continue to catch on? Is this something you are doing at your institution? Can we better study this in clinical trials going forward? How do you see this?
Yeah, I think that I completely agree with you, Mark, that we can really do better in terms of complications and outcome with unilateral surgery. I think, well, I have a few questions. One question is, do we really need to remove these micrometastases, even if we're doing a lobectomy? That's one question. I'm not sure how many patients actually are going to have a clinical recurrence, even if you just do lobectomy and don't do the unilateral central neck. How many of them are we really going to have a clinical recurrence? And in those, if you don't touch the central neck, a lot of times you can go back in and take out what's a clinical recurrence if you really need to. I think if it's a 10% recurrence rate, clinical recurrence rate, or 15% clinical recurrence rate. So that's my first question: is do we really need to remove these micrometastases or not? The second thing is, how do we follow up these patients to know that they're in excellent response? We can't rely on thyroglobulin anymore, because that's also one of the arguments is, but these are intermediate risk patients. We need to remove the thyroid and give them radioactive iodine, and that way we can follow them with thyroglobulin, and they'll have undetectable thyroglobulin, and everybody's going to be reassured. And so I think we need to develop maybe some more standards and more guidelines on how to follow these patients up, what rhythm. And if we're just relying on ultrasound, then we're going to have to, I think, train our radiologists, and a lot more radiologists, to be looking for these small metastatic nodes or these small recurrences maybe. So that's one of the, how do we follow these patients up again? But I agree. I think if we have a unilateral tumor, if there's nothing on the other side, I hope that we could, I think we probably I'm going to have to, I don't know, I would like to see, put it this way, a prospective randomized trial, but those are really, really tough to implement. But yeah, if we could get something like that with some of our study groups, that would be really amazing to have that proof, scientific proof. Another thing we have in Europe also is that, and maybe you don't have that quite as much in the US, is a lot of our patients have bilateral nodules, thyroid nodules. So if we want to do unilateral surgery on everybody, we're going to have, we do the final aspiration on the contralateral nodes, but a lot of these patients already have nodes on the other, thyroid nodules on the other side. So that complicates surveillance a little bit, I think, in unilateral surgery for us in Europe. Anyway, so that's really, for me, that's the thing, is do we really need to remove them? And then how to follow up these patients, and how to convince my endocrinologist that it's safe.
Yeah, sure.
Not to have undetectable thyroglobulin.
Really thoughtful response. Are you what is your current practice? If I may put you on the spot here, and maybe we can also ask Dr. Robenstock from Israel if he can give us sort of what his current experience is as well. But let's say you have a 2-centimeter papillary thyroid cancer, unilateral, and let's just say you have nothing on the contralateral side in terms of nodularity. What's your current practice for a patient like that? Are you going to do a lobe and a unilateral central? Or are you going to just do the lobe? How are you going to treat that patient?
We try to enroll them in a clinical trial, as Mark Erkin said. Initially, we have a national clinical trial in France. It's a non-inferiority trial to show that thyroidectomy with or without central neck dissection. They have that both groups of patients. It's a randomized trial. Both groups of patients have the same rate of excellent response at 1 year. So we've already enrolled 250 patients. And
oh wow!
So we're still trying. We're still trying. So that's one thing we would try to do, just to try to get some hard data on and get this clinical trial going.
So for the audience members that may not be intimately familiar with that clinical trial, so is that a randomized trial?
Yeah, this is a phase 3 randomized trial sponsored by the French National Cancer the Cancer Association, anyway, and it's a multi-center trial. So we enroll patients T1B, T2, and 0, and they all have ultrasound at the centers, specialized ultrasound preoperatively, and we're still doing total thyroidectomy. It's a study that opened in. It got funded in 2015. It opened in like 2017. So it's based on a total thyroidectomy with or without a bilateral prophylactic central neck dissection. And the primary endpoint is the number of patients in excellent response at 1 year. One of the secondary endpoints is thyroglobulin postoperatively. And other secondary endpoints, of course, are recurrences, how many patients are in biologically incomplete response, et cetera, and complications, of course. So that's currently enrolling. So we try to do that. Then if patients don't want to, and we do get a lot of patients now who really don't want to have a total thyroidectomy. And so usually up to T1B, up to 2 centimeters. If the patient, we will, of course, we do what the patient wants, but yeah, lobectomy would be, but I would do a central neck. I wouldn't do a prophylactic unilateral central neck on these patients. I just do a lobectomy. And then if they do have intermediate features, we might discuss completion.
Okay.
So that's about what we do.
Yeah.
We're still conservative about T2s.
So you're probably a little bit more likely to do, given the study that's ongoing, a little bit more likely to do total thyroidectomies for patients than thyroid lobectomies at this point.
Yeah, if patients that are eligible, but then again, we get patients who it's hard because a lot of patients come in and they know what they want, and more patients, and I think it's great, more and more patients don't want a total thyroidectomy, and I actually agree, but we really try to enroll people in this study.
Right.
In the end, we are going to have maybe 40% of patients who are intermediate risk anyway. So.
Well, and there are increasing studies, and I think this is something that we're going to see increasingly studied over the next decade is looking at both the short-term and long-term outcomes, quality of life outcomes of patients who've had thyroid lobectomy versus total thyroidectomy. And I think when you look at large numbers of patients, we're going to continue probably to see a difference there in terms of some quality of life issues, definitely in the short term, but maybe even in the long term as well, for maybe a little bit better for lobectomy as opposed to total thyroidectomy.
Can I just say something? I would like to. Yeah, I think we need some prospective data on recurrence rates though for these patients, because suggested that there is a little bit more recurrence, and like I said, how to follow them up, instead of just saying goodbye, we don't need to see you anymore, and then.
Right.
So.
Absolutely. No, that's a great point.
Yeah, Mark, if I could just interject, and I think you brought up a very good point about intraoperative decision making based on findings and submitting lymph nodes that you identify, and rather than this binary determination of clinically N0, oftentimes I find that just palpation, once you're in the central compartment, which kind of opens up another part of the dialogue of what you're missing with remote access surgery, but palpation can often identify what becomes clinically evident lymph nodes at the time of doing that surgery. And so for me, I'm just asking, actually both of you, how much information do you try to glean from frozen section analysis, either of the lymph nodes or even of the primary tumor at the time of the procedure, that might influence your decision regarding performing the removal of those lymph nodes?
Do you want to? I'll go first. Actually, I don't use frozen section a lot, I have to admit. I think if I saw a metastatic, a lot of them like those little brown or black sort of cystic ones, I would, if I did see them, but usually I don't go and do an exploration of the central neck. So that's one thing. So that's just a practice that I do. I say I don't go in and explore particularly. I wasn't I guess wasn't brought up like that. But I would, however, if there was, and then again, if there was some macroscopic extrathyroidal extension or something like that, that would be, or some tracheal involvement, some nerve involvement that wasn't seen preoperatively, I think that would maybe change my take on doing a central neck, a unilateral central neck. But not necessarily for me, frozen section. But go ahead, Mark.
Oh yeah, no, I think that's a great point. I think I think traditionally, as Dr. Hartl mentioned, not many surgeons have done explorations of the central compartment. I think one of the things that I do sort of as an intermediate step there is to a lot of times when you're taking out the thyroid gland itself, you'll see a couple of lymph nodes that are just sort of sitting there next to the thyroid. It's not I don't do an extensive exploration of the central compartment to find lymph nodes, but a lot of times as you're removing the thyroid, you'll sort of see some lymph nodes there, or you'll I just make a couple of little spreads with a mosquito or a gently curve gently, and just sort of make a few little pockets in there. And a lot of times I'll just kind of see a lymph node just sort of pop out of there, and I'll send that for frozen. Sometimes it's not every single case. Sometimes I do the lobectomy and I just literally don't see any obvious lymph nodes there, and then I just finish with the lobectomy. But I'll often see a lymph node or two just sitting there, or make a couple of little spreads just to try to find a lymph node and send it for frozen. Again, we don't have a lot of evidence that in terms of evidence-based that strategy is effective or not effective, but it is a strategy I think some people employ.
Mark, and so if you identify one positive node, two positive nodes, three, what's your threshold to do a completion thyroidectomy at the time of that procedure?
I don't convert many thyroid lobectomies to total thyroidectomies intraoperatively. There would be only, I guess, two reasons why I would do that. One would be if there were some type of posterior extrathyroidal extension that was sort of unexpected. We've all had cases where there's maybe a small tumor, like a centimeter and a half, or 2 centimeter tumor that's kind of located at the margin of the gland, but then you kind of, as you're getting into the surgery, it's stuck right to the nerve, and you kind of have to do a lot of work to kind of dissect it off of the nerve. And that's a case where, like, I'm thinking, well, this patient's probably, they've got a little bit more risk of residual microscopic disease and may need a completion in radioactive iodine for that reason. So that would be one instance where I would do it. And the second would be, and again, this is sort of a nuanced approach, but the second would be if I was sort of, if I sent a lymph node for frozen and it came back as metastatic, and then I did the full completion, and I started to see like a lot of lymph nodes that were like pretracheal or kind of going over to the other side. And if I sent one of those, pretracheal nodes or kind of maybe even moving toward the contralateral side for frozen, in that, because I'm going to be doing the ipsilateral central compartment dissection, I'm removing the pretracheal nodes anyway. So kind of coming across the midline there. So if I sent one of those and that was positive, I would probably do the completion in that case, just because you're starting to get some nodes that are going more toward the contralateral side. So those would be the two situations where I would consider an intraoperative conversion to a total. I would say that my practice has become, I think, more and more conservative as we sort of have. I've seen the data from Japan and from Memorial Sloan Kettering about, the equivalence of survival with thyroid lobectomy. I've done more and more thyroid lobectomies over the years, where now it's rare that I would do a total thyroidectomy for a tumor that's less than 4 centimeters, unless the patient wants it. My general discussion with the patient going into the room is thyroid lobectomy, and if they want the total thyroidectomy, I will do it. But I'm definitely going into the discussion with a thyroid lobectomy, and I always sort of say, look, you've got a lifetime risk of needing your other lobe taken out, but at the same time, it's probably only about 1 of 6 patients that will need that other lobe taken out in their lifetime. So 5 of 6 patients will get to keep it. And there's really not much downside to taking out the contralateral thyroid lobe, 10, 15 years down the road. Sure, it's another surgery, but, in some sense, that patient's been able to keep even for that 1 out of 6 patients, that patient's been able to keep their thyroid for that 10 or 15 years. So I try to go into the discussion with patients along those lines, that I really think that this is best, the idea of a thyroid lobectomy. And I talk about a unilateral surgery, evaluating the lymph nodes. And then I say there's a low risk of needing to do a total at the time of the surgery. In terms of a completion, I really think there's a much higher bar for taking a patient back for completion. If I get, lymph nodes back and there's 5 or 6 out of 10, microscopic, papillary thyroid cancer lymph nodes in a central compartment dissection, and I did a unilateral surgery, we are not taking those patients back for completion. We just observe those patients. So again, I think that's going to require long-term follow-up. But we already know, in terms of long-term follow-up, that it's not a survival issue. We know that, like, these patients who are not going to die of their thyroid cancer. So the only question is in terms of recurrence, and so when I think about recurrence, while we may not have the data at this point to suggest a really aggressive approach in terms of unilateral surgery, the downside is really there's not a lot of downside, because even if the recurrence risk is double or triple in terms of needing to take out the other half, it's not a life-threatening issue, and it's something that can be done years down the road, and not in a way that's life-threatening to them.
Dana, do you want to comment on that?
Yeah, I think, well, I usually, if I go in and the patient's informed for a lobectomy, has agreed for a lobectomy, even if I find like extrathyroidal extension or as like Mark said, one of those that's stuck on the nerve or the trachea, I'll probably still stop at the lobectomy and do what do you call a staged surgery. We're going to get the pathology back, and then we're going to do the board, and then we're going to discuss with the patient. Then we're going to say, look, we have some high-risk features. This is going to be high-risk features. And then we'll discuss going back, and then we'll maybe have BRAF on that tumor as well, if we didn't have preoperatively. So we have more data to discuss really going back in. So I actually very, very rarely will do completion if it hadn't, been planned preoperatively, because you can always go back in and do the completion. I think one of the issues though that we don't know, because you were talking about recurrence in the contralateral lobe, but there's also recurrence in the neck. And like I said, I just while you're doing the unilateral neck dissection in the central compartment. So I guess that's you're trying to obviate that, get rid of that the risk of the lymph node recurrence. I was wondering also if the practice of doing neck exploration does also sort of create some fibrosis and make it a little bit more difficult to go back in if the patient does have a central neck recurrence. And that's sort of the philosophy behind, at least the way I was brought up, the philosophy behind just doing if doing the neck dissection, if we're going to do it, or just do the lobectomy, but not go in and explore, because then if you really have to go back in and do a neck dissection, it's a lot easier if there isn't that fibrosis in there. So that was just sort of some reflections about that. But I think it's so I had a question, Mark. So you're here for a very low, you went a very high threshold for giving radioactive iodine to patients.
Yeah, we
intermediate risk patients don't get radioactive iodine.
A lot of our intermediate risk patients no longer get radioactive iodine, especially if they're BRAF mutated. If they're like a young or middle-aged female and they're BRAF mutated, they won't get radioactive iodine typically. So I think that's been a real paradigm shift at our institution, and probably a lot of institutions in the U.S. Sort of that de-escalation of radioactive iodine as well. So yeah, I think to answer your other question, I agree that sort of it is a fine balance if you're going to sample a lymph node or two. If you're doing a central compartment dissection to sample a lymph node, then you may as well just do the central compartment dissection. So it's a balance, it's sort of removing a lymph node or two that's sort of sitting right there next to the thyroid, making a couple of spreads, but yeah, you don't want to create a lot of fibrosis there in case you did ever have to go back if you're not going to actually complete the central compartment. So I completely agree with you on that.
So you brought up the issue of BRAF positivity. And so in a patient who's got what otherwise would be considered to be a situation where you've got nothing in the contralateral lobe, it's an indeterminate biopsy, you come back with BRAF positive, and giving you a very high risk of papillary thyroid cancer. Under those circumstances, will you opt to remove the ipsilateral lymph node? Does that change? Your approach to prophylactic central neck here, ipsilateral? Either Dana or Mark?
It wouldn't really for me. It's like, no, we probably wouldn't do it. I mean, it depends on the size of the lesion, but probably wouldn't change much. How about you, Mark?
Yeah, it's a good question. A lot of times, for these low risk patients, we don't actually know the BRAF status up front. I mean, we know that 60% of them or so or more are going to have BRAF mutations. So a lot of them do. But we don't know that up front. I haven't typically based a decision for a prophylactic central dissection or not based on the BRAF status.
Great. So we do have a comment here from Dr. Sugatani, and appreciate his input here. And so let me just go ahead and read this rather than trying to paraphrase it. He states that in Japan, they've been performing lobectomy instead of total thyroidectomy for unilateral low to intermediate risk papillary thyroid cancers. And however, during this procedure, we have routinely conducted ipsilateral prophylactic central neck dissection. While we do not consider to carry out completion based on the number of or size of microscopic lymph node metastases. One of the reasons for this practice is that reoperation on the same area in case of recurrence involve strong adhesions. This is what we were just talking to this point, and is prone to complications. Actually, the previous Japanese guidelines uniformly recommended prophylactic central neck for PTC, but the upcoming guideline revision is expected to refrain from recommending it universally based on recent studies. So maybe the differences in procedures for patients with PTC between countries could have been established considering the amount of iodine uptake in that region, the frequency of BRAF mutation, and so on. So thank you, Dr. Sugitani, for that comment. Mark or Dana, do you want to chime in here?
Yeah, no, I think they're pioneers in not giving radioactive iodine to patients and doing unilateral surgery, and so yeah, no, I think that's great. Thank you, Iwao, for your comment, and we do admire your expertise and showing us that unilateral is safe. But I think you're right about iodine too, though, because we get a lot of patients just with all kinds of nodules, lots of thyroiditis. So there maybe are regional differences in what kind of micrometastases and we're going to be getting when we're doing neck dissection, and the bilateral nodules that are going to come into play when we're deciding whether to do unilateral or bilateral surgery. So though there's things to take into consideration, but that's a great remark.
So let me just ask you both here. Obviously, there are patients. This comes up characterizing the patient's mentality for active surveillance versus surgery, and they're minimalists and maximalists, as we've talked about. If you have someone coming in this scenario who says, I want my thyroid out, I don't want to worry about this, I want you to be able to follow me more closely, will you try to talk them out of that? Mark and Dana?
Well, like I said, we've got the clinical trial. But if we forget the clinical trial, theoretically, I think, and Mark really alluded to this, that young women, in terms of quality of life, in terms of, I think we are more and more conservative in terms of postoperative complications, hormone supplementation, and so yeah, I think I would try to, if the other lobe was completely normal, I would try to at least discuss pros and cons with the patient.
I agree completely with Dr. Hartl. I have tended to become more aggressive over the years in my conversations about thyroid lobectomy versus total. I find that there's still a lot of patients who come in with the bias of wanting a total thyroidectomy for thyroid cancers that are between 1 and 4 centimeters, and even for cancers that are 1 centimeter or 2 centimeters on the low end of that. I think that that fear of the cancer word still pervades, and I think that a lot of patients do come in sort of preferring a total thyroidectomy, and so it does take a little bit of discussion up front. I do really I try to give a balanced discussion, but I do really emphasize that I think that there may be long-term quality of life differences in patients who undergo lobectomy versus total thyroidectomy, and that they should consider that in their decision. And I also, oftentimes they want to know, what would you do if it were you or your wife or your sister? And I tell them that I would do the lobectomy, and that's the truth. So I do sort of push that pretty hard. I find that a lot of patients come in with the total, but I try to push the lobectomy to a certain extent. But if they're persistent and just really want the total thyroidectomy, I certainly tell them that I'm happy to do it. It's ultimately their decision. But I think we've all had enough of our patients who, especially young women, and I think with women, young and middle-aged women, I think doing a lot of thyroid surgery, that we've all had these patients come into our clinic after thyroid surgery, and they'll say, well, ever since my thyroid surgery, I just haven't felt the same, and I just feel tired, and I feel, I have brain fog, and all these things. And there could be other hormonal issues that are at play there that, that are just sort of, it's being sort of pinned on the thyroid surgery. But I think some of that could be real, the T3 to T4 conversion. There could be some real issues there that it's difficult for us to uncover, even though their TSH and free T4 are normal. They just don't feel the same, and they certainly attribute that to associated with a thyroid surgery in some cases. And so I do bring up those sort of points, and usually they kind of say, well, whatever your best recommendation is, and they'll usually go with the lobectomy, but there are cases where they prefer the total.
Right. Well, we are up against the 9 o'clock hour, and this has been an extremely valuable discussion. Truly appreciate the work that Dana, you and your colleagues put in to prepare this, and I greatly appreciate your discussion, Mark. I think it was spot on. It's the question will be moving forward is the issue of prophylactic neck dissection, has it been put to rest here in this subgroup here? I think it remains to be seen. Somehow I don't think that's true, but in any event, thank you both for your comments. It's been terrific. Thank you to our listeners, Dr. Sugitani, for your expertise, and hope you all will join us again next week. Everybody stay well.